Go ahead. So we're going to get started. Welcome, everyone. It's a two-way street, right? Relationship building in communities, listening, connecting, things that we kind of think are basic from like the age of 5, right? But it's just not so basic. So I'm going to have my panelists introduce themselves. Um, let's start with you, Lauren.
Yeah, sure.
Yeah.
Good morning. Oh, come on, Black Church. Good morning.
Good morning.
Good morning.
Yes.
My name is Dr. Lauren Powell. Delighted to be here. And I am head of health equity at Biogen. Been doing health equity work for quite some time, so glad to be here. Yeah.
Thank you, Lauren. Jackie.
Thank you, Terri. My name is Jackie Ingram. I'm principal for health equity at Genentech, and I represent the work that we do at Genentech for all of our customer-facing teams. So on the commercial side, doing the work in the community, making sure that we're advancing the spread and the sharing of disease education, access to medicines, as well as advancing all efforts for earlier diagnosis and treatment for a variety of diseases. Happy to be here.
Thank you, Jackie. Ricki.
Excited to be here to have this conversation. I'm Ricki Fairley, the co-founder and CEO of Touch, the Black Breast Cancer Alliance. I'm a 12-year survivor of triple-negative breast cancer, so this is my God job. And I like to say that we are in the community every day. I like to say that we go where Black women live, work, play, pray, and slay.
Yes.
Thank you, Ricki. Before we jump in, just a reflection from the last panel, which I would say, Dr. Tuckson, thank you so much for that authentic voice. And as the kids say, keeping it 1,000% in terms of what we're really talking about here or not talking about. For all of our panelists, you have a remit around health equity. And that remit requires that you do dig deep and go into community, whether you want to or not, right? Because, some folks choose to stay within the four walls, choose not to engage authentically because you have to be in a place to feel a place, right? So I want to hear from each of you how you've gone about your work in terms of listening with community, being in community, and creating what I call that connective tissue. Lauren, do you want to start us off?
Sure, I'm happy to. So my remit at Biogen, and by the way, I've been there for like 50 days, so it's exciting. But I can talk about this from lots of different perspectives. But at Biogen, my remit is really focused on embedding health equity throughout the entire drug development process. So a lot of us have been talking about diversifying clinical trials, which is certainly very important. But if you wait until the point of like conducting a clinical trial to start think about diversifying, you're like waiting too long. Right? That's way too far downstream. So my job is to think about this much further upstream in how we can prioritize ensuring that underrepresented and Black and brown communities and lots of other communities as well are prioritized and thought about long before getting to the point of a trial. And of course, with that comes the need to engage with community and to ensure that the process is being informed by those who we really want to reach on the ground. And, I always think it's important to make the delineation as we talk about this between community outreach and community engagement. We have a lot of organizations who say they're doing community engagement, but they're really doing outreach. The difference between the two is that outreach is transactional, right? It's not about a relationship. So it's me showing up, handing out some flyers, and, the institution is the one who benefits from community outreach. Engagement is about building a relationship. It's bidirectional. And quite frankly, the community is who is supposed to benefit from community engagement. So if you're doing work in which the community is not actually prospering, then you're doing outreach and not engagement. You should be very clear on the difference.
No, thank you for that. Thank you for that.
Yeah.
Jackie, you want to comment on?
Yes, and I want to piggyback off what you said because you educated me about the difference between those two. I was using those two terms synonymously. And what I realized, I had this light bulb moment, what I realized when you had explained that to me is that Genentech, I believe, has grown Because I think in the beginning, we were doing more outreach than engagement. Now, and not to brag, but now I can say that I'm proud that we've learned
Yeah.
the hard way that engagement is really what needs to happen, where you're truly, and I think someone said it really nicely earlier. They said, if you don't have one foot in the community, you can't really do the work of the community. And so we've learned that we have to show up, representation matters, and you really have to be embedded in the systemic changes that have to happen. You can't just be handing out flyers
Right.
and expect to make a difference. But we've had to learn that the hard way. So I just want to thank you for putting a fine point on that so that now I can be very clear when I say we engage in community engagement and not outreach so that the outcomes can be better for all people, especially those who are underserved. So thank you for that.
The patients can see it.
Yeah.
So I think, let's talk about why we need community engagement. Why do we need it? And I believe that our health illiteracy in our community is breeding health inequity. Because our people don't know. They just don't know. They don't understand. They don't know what a clinical trial is until they're faced with it. They don't talk about health at home until Uncle Pookie gets his leg amputated. They don't talk about, really her stories, their histories. And so we need to educate our people at a very basic level with words they can spell,
Yeah.
with examples they can see, with stories they can relate to. And that's why it's so important for the patient to really get the message from you guys, from pharma, from whoever. They have to understand the basics. And normally when they face something that they need to know about, they're in crisis.
Right.
They have metastatic breast cancer or metastatic prostate cancer, and they're in crisis, and they're trying to learn everything through this, the hose that's coming at them without knowing anything, and then never having dealt with health before, having avoided hospitals if you're a Black man. And so it's really important, that engagement, and I think we try to show up in a way. I like to say that we're impatient about being iconic. So when we go into the community, we do something crazy and weird and wear tutus and wear bikinis on the beach, pink bikinis. Haley made crazy bikinis to wear at Martha's Vineyard this summer. But we try to do something where people walk away having had an intervention with us. So they walk away having learned something and taken away something from us. And if we don't do that, it's not effective.
Ricki, I just want us to touch upon something that you just said in terms of our communities not knowing what health equity even means. I believe that BDO has collected data on that, and it's something like almost 70% of
Right.
Black folks said, it's a conversation, but I don't even know what that is. Well, how can you know what something is when we as a people have never seen it really, right? Okay, so you don't know what you don't see or observe. So what are your thoughts in terms of the second part of that narrative with what I'm hearing is, people are starting to equate health equity with DE&I. And especially in these times, and we're entering, an election year, DE&I is being, made secondary or in third place in terms of, no, we're not going to talk about DE&I. Given what the Supreme Court said, we're going to move to opportunity. So is it the case that so goes DE&I, where there's disinvestment? Is this going to remain a hot topic? Is this something that we're going to double down on? Being that it's a so-called new conversation for many. What are some of the panelists' thoughts on this?
Let me collect myself.
Go for it.
Go in.
Go for it.
I think where we are is not by happenstance. I think there's nothing new with the very antagonistic and very intentional backlash on diversity, equity, and inclusion, especially following this wave of America's, I guess, remembrance of the fact that racism still exists, right? So all of that happened like post George Floyd. It was like, oh my gosh, racism, like we should all be anti-racist. Yeah, we should. But then, so I think of this as like one of Newton's like laws of physics, maybe the second law I think was for every action, there's an opposite and equal reaction. That's what I think of this as, this whole moment. And unfortunately, I don't think it's going to be a moment. I think it may be a little bit longer than we think. Now, the question for me really is, like, the pushback on DEI is definitely happening in real time. It's definitely hitting corporate America. It's definitely hitting jobs. It's definitely, making a really big difference in the education world, right? I am really unclear as to what will happen with health equity. We do have some examples of what's happened in some states that are more perhaps conservative leaning, and the erasure of the word equity altogether, being replaced with opportunity, which is rather whitewashed, right? Opportunity for who? Let's be specific. So I think there's more to come, but this to me underscores the importance of knowing what health equity is. So we have a lot of leaders who are very good at using the word health equity in a sentence, who are very good at throwing it out in front of audiences, who are good at tossing it into a grant. But if I asked you to define health equity, could you actually do that? Do you understand the principles of it? So I think this is why it's necessary for us to understand the principles of health equity, because even if they change the title, say we can never use the words again, you can still do the work.
Thank you. Thank you for that. Jackie?
Yeah, thank you. I think that those two concepts are very distinct. What we like to say is that they're similar, they're not synonymous, they're close cousins. I do think it's important for people to understand the difference, and certainly at Genentech, they're two different, distinctly different concepts. I am more optimistic about health equity continuing, and the reason is because I think it's fairly simple to make the business case for it. And so, unfortunately, the moral imperative to do the right thing sometimes isn't enough, and it's sad to say that. But you can always make a business case for doing the right thing. So if you don't care about black and brown people, you certainly care about the green dollar. And so I like to look at it as market segmentation. So if you've got black and brown people over here, you've got Caucasians over here, and all these other different ethnicities, and if you are ignoring this whole population of black and brown people, that wouldn't make very good business sense. Right. So that's why I'm saying the case is there, it's simple, I think it will continue, and I believe that there is a moral imperative, and we feel the moral imperative to do the right thing. We don't want to ignore patients, but there's clearly a business imperative, and that's why I think it will be sustaining.
Thank you for that, Jackie.
Yeah.
Ricki?
I have to bring the patient voice again, and I
Yes,
love that you guys
yes.
have health equity in your titles and that they're your jobs. But I don't believe we have any concept of health equity in our world. So the patients I see come to me and say, well, my doctor didn't ask me for genetic testing. My doctor didn't do this for me. Or I bring up, did the doctor do this for you? And they say no. And they have no clue even what to ask for. And I don't believe we're going to get to health equity until everybody in our ecosystem practices the golden rule, what your mother taught you when you were 2 years old. Treat others as you want to be treated. And so I can't solve racism, I can't solve illicit bias, but what I can do and what I do is educate black women on what they need to ask for and what they need to demand and the health care that they deserve. And that's what we do every day. We teach them. You go back to that doctor and you say, would you recommend this plan for your mama, your auntie, your grandma, your daughter? Because if it's not good enough for you and your family, it's not good enough for me. And we're seeing the patients come to us saying, they're giving us evidence that they're not receiving equity in their health care every day.
Yeah, thank you for that, Ricki. I knew what your response was going to be given your powerful voice, and I would suspect that if companies today or tomorrow stop funding whatever, you're going to still keep the drum beating, right?
Every day.
Every day, no matter what. And that gets me to just thinking about the last panel and Dr. Tuckson saying, this can be rather daunting and depressing or what have you, and that we must be brave in terms of stepping out of our comfort zone. And that panel actually started off talking about drawing on the HIV community, the HIV response, as a response to COVID, and I'm looking at Rashad Burgess from Gilead, for instance, who can appreciate this. You know, even before companies started investing in HIV, there was a drumbeat that LGBTQ and Black communities were going to continue beating because of how it was affecting our community. Until this day, that drumbeat still beats, and people may not like you. It's about taking you may not be a like person, right? And some of my clients who are in this room right now, they're like, Terri, get off of it. It's like, why are we talking about HIV? I do rare disease. I do oncology. The doctors who came up here were so smart in terms of who they drew upon, because there is no discussion about community engagement in HIV. It's the work. There is no conversation about health equity in HIV because it's the work. Says no one are we holding up polls demanding health equity. It's way beyond that. And you asked me a great question yesterday, Jackie, about, you know, tell me more about this, you know, the HIV response and how to apply it. And what are you thinking in terms of that last panel, in terms of being brave? Because I'm sure your jobs are not easy many times, because, you know, everyone in the company is not on the bus of health equity. So how do you deal with those challenges?
Do you want me to answer?
Yes.
Okay. Well, one way to deal with it is by being more transparent. I think, you know, we all have friends from a variety of backgrounds, cultures. When you work with people, sometimes they see you as just a colleague. But when you're African American and they're not, they may not understand the challenges that we have faced for generations until you start sharing stories with them. So in my case, you know, as it turns out, I happen to be working on a number of health equity initiatives, including one on diabetic eye disease. But my personal why is I've seen what good health care and bad health care looks like in my own family. So my mother, who just passed 2 years ago from complications of diabetes, unfortunately, but she lived to the ripe old age of 89 years old, okay? She got excellent health care and she got great education, and she had providers who cared. And they told her not just about make sure you take your insulin, but you need to make sure you're exercising, you need to make sure you're eating right. So she got a 360-degree, you know, comprehensive plan for what she needed to do to be her best self. Years prior to that, her own aunt also had diabetes. So clearly it runs in my family. She had diabetes. She was old school, did not trust the health system. So she didn't even get treated for diabetes, although she did go to the doctor. She didn't trust what they had to say. She ended up passing at only 60 years old after she had already had a foot amputated and she had gone blind. So in my own family, I have that juxtaposition of experiences. And so I told that story to a few of my colleagues, and it was just such an eye-opening experience for the white folks who just didn't understand how drastic it can be. I mean, you read it on paper, blindness, African Americans and elderly people are at the highest risk of visual impairment or blindness as a result of diabetic eye disease. But until I told that story, it was like it didn't really resonate with them. So that's just one example of what we can all do to make sure that people are more enlightened when there is pushback.
Thank you for that.
Yeah, I mean, I think this is a very uncomfortable topic for some people, for a lot of people, quite frankly, because they don't have the same lived experiences, or maybe if they do, there are certainly tinges of racism, and that is just real, right? So I approach this a little differently. I don't think it's my job to change everybody's mind. It's just not. I don't have time for that. So I work with the folks who want to work with me. Some will be converted along the way, some will not. And that's just how it's going to be.
Could I add something there too?
Yes, Ricki,
You know,
yes.
I often use HIV as an example. You know, we talk about clinical trials a lot, and we have a campaign, When We Trial, and we've signed up 17,500 Black women for clinical trial portals in the last 2 years. And it's not enough. But one of the things that I tell people, Black women have a 41% higher mortality rate of breast cancer than white women. And I could give you so many bad statistics, they're horrible. It's actually a crisis for Black women. And the fact, I tell the story all the time, when HIV first hit, I was a dancer. I'm old. I was a dancer. And I would watch people in my dance class disappear. They'd sneeze and say they're going to die. And so back then, a clinical trial was the only drug you could take. And so everybody jumped to go to clinical trials because that's all they had. They didn't really have a choice. There were no other drugs, almost like the COVID vaccine, right? But they jumped to them. And I use that as an example for breast cancer because if you're a Black woman under 40 and you have triple negative breast cancer, a clinical trial is your best option because we know we don't have the drugs that we need for this horrible disease. And so I say, take an example from AIDS. And I actually got that from Dr. Gigi. She helped me come with that story. She left the room. But use AIDS as an example for, this is why you should do a clinical trial. Mm-hmm. It's all you have. It's the best thing you can do for your body, for your disease. So,
Thank you for that. Michael, thank you for joining us. Do you want to introduce yourself and perhaps comment on this subject?
Absolutely. So first, apologies for being a few minutes late. I am fresh off of a plane from Vietnam, where I had 13 days, which I thought would be relaxation, but it was traveling throughout Vietnam. So glad to be here. I think there's a few things. So one, introduction, Michael Curry. I'm president and CEO of the Massachusetts League of Community Health Centers, which represents 52 health center organizations throughout Massachusetts. I call that my paid job. My unpaid job is I'm a civil rights advocate, activist, former president of the Boston NAACP, and a longtime leader on the National NAACP Board of Directors. Very engaged in advocacy and policy issues throughout the country, health being one of them. There's a few interesting things. So one, appreciate the comments. Dr. Lauren is I'm a biggest fan of hers because during COVID, we were often called upon to be on panels. And one of the phrases she said on one of the panels, I think took people by surprise. She said, they don't trust us because we haven't been trustworthy. And I've been using that ever since. But I say that to say that one of the things that came out of that conversation and that work was what can we do now, engaging communities, getting them involved in this heightened awareness around health equity. I immediately called some good friends in Boston and ended up launching what essentially would be the first Institute for Health Equity at a primary care association, possibly in the country, but definitely in New England. $6.5 million we raised in 3 months, and now we have an entity doing cutting-edge research on many of the critical issues. We often say we've partnered with Harvard, we partnered with pharmaceutical companies, but we're often waiting for them to ask the question instead of us asking the question and asking them to partner. We call it emancipatory research. And hired a phenomenal physician out of Harvard, Dr. Cheryl Clark, to lead that work. So that was a great step in the right direction. The next thing we did is we decided, one of my favorite phrases, and I see my good friends from Boston Medical Center here, Dr. Thea James and Trina Martin and the rest of their team, we popularized the phrase weathering in Massachusetts, coming out of Dr. Geronimus's research in 1990 around women's maternal health, and this disrupting this notion that women were having bad outcomes because they were young, they were teens, Black women. And of course, her research revealed that they were actually having better outcomes than older Black women. And in large part, she coined the phrase weathering, that the older you got, 20s and 30s, racism, poverty, trauma, and everything else was impacting your maternal health. So I asked the question as a person who grew up in a housing project, single mother moved to Massachusetts for the warmth of other sons from Alabama. When I went around my house and in my neighborhood and went to family reunions in Birmingham and Tuscaloosa, we would be lucky to see someone past 60, 65. Because many of them, we'd come to a reunion, I'm 5, 6, 7, 8, 9, 10 years old. I'd go sit with the elders. And I literally, even at that age, knew I may not see them again. And I had no concept of health equity, but I knew they had diabetes, heart disease, every form of cancer, and they looked sick at the reunions. Yeah. And I kept saying throughout my professional career, why are we not disrupting this? Why are we weathered to the fact that we live sicker and live shorter lives? And of course, the work that we all do is disrupting racism, but this is a part of that. And then that led to this conversation around right now in Massachusetts, but this is true across the country, we have more Black and brown folks with lived experience leading healthcare entities than we've ever had before. Life sciences, hospitals, health centers, oral health organizations, eye health organizations, colleges and universities, teaching academic centers. Why are we not pulling that lived experience together in one place and saying, why don't we move an agenda together? Because there's something different that I say, if women ran everything, there would be no maternal health crisis in this country. And I don't say that for a clap. I say it because I'm a policy person. So I know if you ran everything, that would be top on your priority, because it's your babies, it's your loved ones, it's you that have experienced bad outcomes in pregnancy. So why don't we now turn this critical mass of Black and brown folks who are leading institutions and have a seat at the table, or who have created the table, to now drive an agenda to change health equity. Tremendous progress in Massachusetts. We've filed an omnibus bill, which is moving through the legislature. We've pushed. We now have quantified what the cost of inequity is in Massachusetts, $5.9 billion in a year, and popularized the phrase pay now or pay greater later. So I can actually invest in keeping you healthy, or keeping you out of the emergency room, or can invest in getting you into research and solving for these conditions, or I'll pay greater later when you're in the emergency room, or you're inpatient in a hospital, or you're not available to work and be productive in our society. So I just think it's a critical time in our conversation, and if not now, then when, and if not us, then who?
Well, Michael, thank you for that. And I like where you've taken the discussion, which is a focus on what is working well. What does resilience look like? Because, for most of we've been focusing on what the problems are and the barriers, but I'd like to go to, what is exciting people? What has success look like for you? Because you don't do this work and get to the grind without having some success and what you want to double down on. So, Lauren, maybe you can start us off with I know that you're new in your position, but I'm talking about what you've seen, especially as a practitioner, a doctor. What have you seen work well that we need to have a little bit more of that?
Yeah, I think there have been quite a few things that have worked well, especially actually during COVID. I feel like we had to get so creative during COVID, and also it was a broadly recognized moment of urgency. And that's something that I think we should really take hold of and take account of as we continue to do this work. Like COVID, everyone just kind of jumped in and did everything, right? So we had public-private partnerships. We had like Bacardi creating hand sanitizer, and everybody was doing everything that they could. And I just wonder why we can't treat health equity the same way. But I think some of the great things that came out of that time, I don't know if Dr. Letha Maybank is here yet, but I love some of the work that the AMA is doing. I know that they have partnered with organizations like Afropunk and sort of music festivals and in places that we already know our people are, and we can actually meet them there. So I think we need to do so much more of that, and continue that creativity and recognize public health and healthcare doesn't have to be boring. It doesn't have to be boring. It doesn't have to be tasteless. It doesn't have to be in places with white walls and white coats. It can be fun, and it can be relevant, culturally relevant. So those are some of the things that I think are great.
Thank you, Lauren.
I agree. Very quickly, our mutual friend, Lauren Crandon, is the founder, also a breast cancer survivor, is the founder of an organization called Touch for Life. And so she has these events across the country that are a party with a purpose. We need to do more of those parties with a purpose because they're successful. And basically, they're in the Black community. She partners with the Divine Nine. The one that recently happened was the Prince George's County National Panelists Council, that chapter. It was equivalent to like a nightclub, packed with folks, African Americans, learning about cancer, early disease detection and treatment. And it was incredible. It was awesome. So to your point about creativity, I couldn't agree more. +1 on that. Need to be more creative. the other thing we've learned is just partnering with entities that already have the trust of the community. We can't just come in prescribing this and prescribing that. We really need to listen and anchor to those entities that have the trust already, like National Minority Equality Forum. We did that recently in Flint, Michigan. Everybody knows about the Flint water crisis. We were able to attach ourselves to NMQF after the data was clear that there's one particular zip code, 48505, I'll never forget, in Flint. The Michigan, can't remember the entity, but the data was clear that the cancer rates in just that one zip code were higher than the entire state of Michigan. So our efforts to partner with NMQF and to go into that community and to help them to get the resources that they needed and to educate them on exactly the risks of cancer that they were dealing with, just it was an eye-opening experience for them. But my point is attaching ourselves to NMQF is what made that successful, not us by ourselves.
Thank you, Jackie. Ricki?
We do similar to what Laura does too. We meet people where they are with culturally agile messaging. We don't go to health fairs. We go to events where Black women are hanging out. Hair shows, beauty pageants, whatever, kind of community organizations. We partner with Jack and Jill and the Links and the Divine Nine and all of the community organizations. But we actually are doing an event this summer in Martha's Vineyard, when all the bougie Black people are there the third week of August. Right? And so actually my daughter Haley over there, we rented a house in the middle of Oak Bluffs, and we're going to do DEXA scanning. So have women come and get scanned, get your breast scanned. While you're there, you get a free scan and try to make it a family tradition. So when you come to Martha's Vineyard, on the third week of August, you can get scanned. Come with your mama, your auntie, your daughter, whoever. And Haley designed these crazy bikinis that we're going to wear and walk the beach. Right, walk the beaches in our little bikinis and bring people to our house to scan them, so to screen them. And I think we have to be creative in how we reach out, but we do all kinds of events where we try to do something. We do roller skating parties. We do, we try to go where people are and talk to them with messaging that we test. We test every word. We also use a lot of video content with testimonies of blessees and have the patient talk, the patient voice, explain the story.
Thank you for that. Thank you, Ricki. Would you like to comment on that, Michael?
Yeah, so I want to correct the record. Not everyone in the vineyard in August is bougie. Because I'll be there. But no, so appreciate the work that you're doing. I think there's a few things. So one is the critical part of this conversation, and it comes out of the conversation I walked into around the HIV/AIDS work, the Nothing About Us Without Us movement. And what we learned, and we sort of modeled this during the COVID, was that you got to go to where people are and have conversations with them. So, Patrina Martin's a good friend of mine from Boston Medical Center. I remember her calling me and said, Michael, we need to do vaccines in churches. We need to work with our ministers who they trust and go into communities. And I got both my vaccines in my church through Trina and Boston Medical Center. And then we started talking about opening up parking lots and investing in these nonprofits that are very little funding, may not have the infrastructure. How do you put money in their hands to do the great work that they do to make sure that people are getting the care that they need? It's unfortunate, as I think was said earlier, that it took a pandemic, once in a century event to drive us to do what we know works, to engage people, engage community, empower them, and then drive an agenda together. So I think going back to what I mentioned before, this sort of weathering thing, in the civil rights work that I do, and I chair the National Board's Advocacy and Policy Committee. And one of the things I always say at my committee meetings is it's great to address voting rights. It's great to and try to pass these bills in Congress on state legislatures. It's great to move an agenda around debt relief as we disproportionately have higher medical debt and academic school debt. I said, but the one critical thing that we sometimes overlook is educating people. That if you educate them that it is weathering to live in a community where when you get in a car you're likely to be stopped and harassed, or that you're likely to serve a longer term in prison. It is weathering to know that you have higher rates of diabetes, heart disease, almost every disease I can name, and you will live a shorter life. So how do you then go to community and make them aware that that's not fair and it can be addressed? because the policy stuff we can do. But what happens too often is we try to do this work and then we show up without the army of people who built the consciousness to show up and support you. So they don't vote, they're not engaged, and yet they're the ones most impacted by these things that we talk about. So I honestly really grassrootsy when I say this. And folks in this room who know me know this. I take every speaking engagement people ask me to do, even though I have the time to do it. Because the reality is, I want to bring the gospel about health equity, public health, and that we can do better in this country. And we should be doing better by people of color, and particularly when I say African American folks. And the only way you do that, I go to clubs. I'll be standing in the middle of a club, believe it or not. And the host or the promoter of the night will say, Michael, you got 10 minutes to talk about health equity. And they will stop people from dancing. Now, I don't know if you've ever experienced that. But they will stop a packed club of 200 people from dancing and give me the microphone to inspire and empower them about how they can live healthier lives and demand more of society to help them live healthier lives. That's the kind of grassroots groundwork we need to do.
Yes. That's some old school HIV
Yeah.
work, right? Yes.
Can I add one quick point?
You get
I'll
the
be
last
fast.
word,
I'll be fast. So you know what? Our people are doing it. We see it in breast cancer every day. There are women in our community who may not have never been to an ASCO, may not have ever heard of blackdoctor.org, but they're in the community. Yeah. They're helping women. They're driving people to chemo. They're holding your head over the toilet when you're vomiting. They're doing the work. And so we actually are building an organization called Belong. Blessed empowering leadership and opportunity and nurturing growth. And we're reaching out to these women. We're trying to build an organization where people are have somebody in every state. We've now accessed 43 states, 90 organizations where they're just women who just don't have a lot of resources, but they're doing the work. They're helping other people deal with cancer. And I think if we garner them and give them resources, we're trying to nurture them, nurture the leaders who are doing the work. And I'm saying this to all my pharma partners. Next year, I'd love to build a fund of $1 million that I can give resources to these women that are being the leaders in their community and doing the work. So I'm just calling that out right now.
Yeah.
Because we need to help them, and they're already there. So bringing them resources, bringing them money, giving them education, and that's what we're doing. We're just educating them every month with webinars.
Thank you very much, Ricki. I want to thank all of my panelists. You used the word gospel, Michael. So I would say, and keep me honest, Ricki, the theme of this gospel has been, and this is to all of the companies, there's a difference between outreach and community engagement. Community engagement is not transactional. It's building connective tissue. And also in terms of community engagement, you have to go where people live, work, play, and slay.
Pray and slay.
Pray and slay? Okay, pray and slay. It's high touch, people. I know that the tradition with pharmaceutical companies is to work directly with organized patient advocacy groups. You got to amplify that. You got to go into communities and go to other civic organizations where Black people are thriving and supporting and building their communities. So thank you, everyone. Bravo.